Okay. Well, good afternoon, everyone, and welcome to this teaching session. Look, today I wanted to talk about something we haven't spoken about before, and that's inotropes and vasopressors in children. And we've talked a bit about the this is the acute management of children with shock or the management of hypotension. We talked a bit about that in the past, but I've never really covered inotropes and vasopressors. And I think this increasingly there are um, uh, critically ill children with septic shock or some other illness that require some inotropes or vasopressors, whether it's severe rheumatic heart disease in children who've got heart failure, and you need to give them some inotropes just while you're treating their acute deterioration in other ways. And so we need to know how to use inotropes and vasopressors and what they mean. So that's what I wanted to talk about today. As I mentioned, um, the series of lectures, if you want to look at the foundation aspects of pediatrics, then go back to the 2023 and 2024 lectures because they are really the foundational or the core aspects of pediatrics. And then this year I've just been presenting some things that we haven't talked about before. So we'll start about inotropes and vasopressors. The first thing to say is that we often think that inotropes are um, for blood pressure, but blood pressure is only a way of actually achieving oxygen delivery to tissues. And it's not always that a normal or high blood pressure achieves oxygen delivery to tissues because when we think about the purpose of using inotropes or think about the purpose of using vasopressors, then we are trying to maximize or optimize the oxygen delivery to tissues. And the oxygen delivery to tissues, the oxygen delivery equation is the cardiac output times the hemoglobin times the oxygen saturation times a factor of 1.31. And if you think about the cardiac output, we don't actually we can't. It's hard to measure. It's hard. It can be measured with Swan-Ganz catheter, or sometimes it can be estimated using echocardiography. But usually we infer the cardiac output, and the cardiac output is the heart rate times the stroke volume. And so when certainly for children, they can increase their heart rate substantially and that can augment their cardiac output. And that's what happens when a child's got hypovolemia or they're in shock. There are other ways to increase the stroke volume. That is increasing the preload on the heart or increasing the contractility of the heart. So one way to improve oxygen delivery is to improve the cardiac output, and that's what inotropes can do. Not always, but they can do. The other way is to improve the hemoglobin because that increases the oxygen carrying capacity of the red blood cells and generally speaking, that improves oxygen delivery to tissues. And a third way is increasing the oxygen saturation, the SpO2, the oxygen saturation measured by pulse oximetry, and uh, and that will improve oxygen delivery. Now, in many of our patients, the oxygen saturation is adequate because they've received oxygen. The hemoglobin is not too low, but what we can do sometimes is to optimize their cardiac output. The factor of 1.31 is the amount of oxygen carried by 1 gram of hemoglobin. Zita, I was just saying that the aim of inotropes is not primarily to increase blood pressure, but it's to increase the oxygen delivery to tissues in children who have hypovolemia or they have septic shock or cardiogenic shock, etc. Now, this is a little complex, and I'm only going to go through it in brief, but the there are various receptors in the body, in the blood vessels for inotropes. And if you think about the different inotrope receptors, then you can understand what different inotropes do. And again, you don't need to know this in great detail, but the alpha 1 receptors stimulation of the alpha 1 receptors lead to arterial vaso or constriction, essentially vasoconstriction. Stimulation of the alpha 2 receptors lead to arterial constriction, especially of the coronary and the renal vessels. Beta receptors improve chronotropy, that's the heart rate, and contractility. of the heart. And they cause selected arterial dilatation, which could be advantageous, cardiac coronary artery dilatation, and skeletal muscle dilatation, not so advantageous. But beta 1 receptors, if you stimulate them, then they increase heart rate, they increase the contractility of the heart, and they can lead to improved coronary perfusion, for example. And then you've heard of beta 2 receptors, and you've heard of them mostly in the target receptor um, for salbutamol or bronchodilators, because the beta 2 receptors cause, when you stimulate them, you cause bronchodilation. So Ventolin or salbutamol leads to bronchodilation because of the stimulation of beta 2 receptors, but they also increase chronotropy. So that's why when you put a child on salbutamol, um, then their heart rate goes up. It also increases their contractility, and they get muscular arterial dilatation, again, not so advantageous, but some cardiac or skeletal muscle arterial dilatation as well. So the yeah, and then there's some dopamine receptors, which are not alpha or beta, but they're D receptors. So D1 and D2, they cause vasodilatation of the peripheral vasculature. And um, so dopamine increases heart rate. It does increase contractility somewhat, but it causes vasodilatation. And then there's other receptors called V1 receptors, and um, they're acted upon by vasopressin, vasopressin is the strongest endogenous vasoconstrictor in the body, and sometimes we use vasopressin as a vasopressor agent. Then lastly, there's a group of receptors called phosphodiesterase receptors, and the type of agents that act on phosphodiesterase receptors, PDE3 receptors, are drugs, inotropes like milrinone, and also aminophylline. Aminophylline functions by phosphodiesterase inhibition, leading to vasodilatation and increased contractility of the heart. So the main ones I want you to focus on are the target receptors for adrenaline and noradrenaline, and particularly those two anyway. I'll talk a bit about dopamine and dobutamine, but not so much because they've really gone out of use a lot, and I'll try to explain the reasons why. So, as I said, I think it's good to focus on um, two agents, especially adrenaline and noradrenaline, and I'll say a bit later on about hydrocortisone. Some of these other inotropes that I've listed there, they're dobutamine, dopamine, vasopressin, and milrinone, either won't be readily available or they've gone out of use somewhat, particularly dopamine. And so adrenaline is an alpha 1, alpha 2, beta 1, and beta 2 agonist. It stimulates those receptors, those catecholamine receptors, and it leads to increased contractility and some peripheral vasodilatation, and that can be useful. It increases heart rate, increases contractility, and it leads to some peripheral vasodilatation. So if you think about it, for many children who've got, for example, impaired myocardial function from rheumatic heart disease or acute rheumatic fever, or they've got a septic cardiomyopathy where their cardiac function is low, they'll benefit from some adrenaline. Now, we've all got adrenaline and noradrenaline circulating in our body. We've all got dopamine too circulating in our body, and that during a period of fever or sepsis, we get an adrenergic surge. But for some children who've got impaired myocardial function, they'll benefit from some extra adrenaline. I'll explain who benefits in a little while. The second agent I want you to know something about is noradrenaline. And noradrenaline has one different property, and that is that it increases contractility, but it also increases vasoconstriction. And so if you've got a child who's got severe warm shock, as in they've got vasodilatation and low blood pressure, then noradrenaline is often the drug to use. I'll explain the differences between adrenaline and noradrenaline when we use one over the other shortly. I'll talk a bit more about hydrocortisone later and its, or any other steroid, and its benefit to inotropy and how it can augment the effect of other inotropes, and why it's useful in septic shock. And I'll say something about calcium as well, because it's something we have access to generally. First of all, we've reviewed the oxygen delivery equation, but I want to also just recap on the different types of shock. And because some types of shock don't benefit from inotropes and some types of shock do benefit from inotropes. And it's really important that we know the distinction. And clinically, we try to identify the differences between the different types of shock so that you only use inotropes, whether it's adrenaline or noradrenaline, when it's beneficial, and not use them when it's potentially harmful. And so the first type of shock, the commonest, is hypovolemic shock. So from gastroenteritis or severe dehydration, from vomiting and diarrhea, from hemorrhage, and some forms of septic shock, you get hypovolemic shock. And in most cases of septic shock, especially from dehydration and or from hemorrhage, inotropes won't be of much benefit. In fact, they may make it worse. If you've got an empty circulation and you squeeze it with vasoconstrictors, or you try to drive the heart faster when it's largely empty because there's hypovolemia, then that actually makes things worse. So these patients, they don't need inotropes, they need filling up. If you've got hypovolemia, they need to be filled up. I'll say more about this in a minute. Then there's cardiogenic shock, where there's poor contractility, and that might be from myocarditis or rheumatic heart disease or arrhythmia or ischemia to the heart or sepsis. You notice that sepsis comes into both of these, into hypovolemic shock and into cardiogenic shock. I'll talk more about this overlap in a moment. And then the third type of shock is vasoplegic shock. So we've thought about hypovolemic shock, where there's not enough blood in the circulation or a fluid in the circulation because of dehydration. We talked about cardiogenic shock, where the heart itself, the muscle, is not pumping well. And then there's vasoplegic shock, where the blood vessels, instead of having their normal tone, are much more dilated. And if all your blood vessels are dilated, then even if you've got the normal amount of fluid in your blood vessels, then you'll have low blood pressure because they're just more dilated, and the capacity of the circulation is much greater. So you need more fluid. So vasoplegic shock is the third type, and that occurs typically with sepsis and with anaphylaxis, where you get vasodilatation, and with neurogenic shock. So in children, for example, if a child has a severe anaphylactic reaction, what they're having is vasoplegia. Their blood vessels are losing their normal tone and they're becoming dilated, vasoplegia, instead of the ability to constrict the blood vessels when low blood pressure occurs. They then are unable to constrict, and they're vasoplegic instead of vasoconstricted. So that happens in anaphylaxis, but it also happens in neurogenic shock. If you've got a child who's got a spinal cord injury, then the normal nerves that go to all the blood vessels don't function, and so therefore there's vasodilatation. That's typical in spinal cord injury. The classic features of spinal cord injury on neurogenic shock are where you've got bradycardia and vasodilatation. In sepsis and anaphylaxis, you usually have tachycardia and vasodilatation, but so that you can make that distinction clinically. And then lastly is anemic shock, where the hemoglobin is just too low for there to be adequate oxygen delivery. So knowing the different types of shock and trying to be able to distinguish them clinically is quite important. I'll talk about how to do that. Now, if you've got hypovolemic shock, those patients usually don't need inotropes. They don't need inotropes because it will sometimes, as I said, if you've got an empty circulation, it'll actually make it worse. It's squeezing or driving an empty
Está en static.
circulation.
Sí.
But what these patients most need is fluid. So they need whatever they've lost, they need. And if they've lost blood, they need blood. If they've lost um, uh, fluid through dehydration from vomiting and diarrhea, they need crystalloid fluid, a balanced salt solution, Hartmann's, or we've talked about that. And if they're if they've lost protein, then they may need albumin, and I'll mention some reasons for that. But if you've got hypovolemic shock, then you first, at least as a first step, you need volume, fluid volume. Inotropes will only make it worse if you use that in that circumstance. But when I was talking about the different types of shock, uh, hypovolemic, cardiogenic, vasoplegic, anemic, then all of the different types of shock can occur in sepsis. And this is important because in any child who's got septic shock, then there'll be different um, proportions of the shock that are due to hypovolemia, such as if the child's had fever and vomiting and diarrhea for several days, they might be hypovolemic, then they need fluid. But they might have a very poor intake, they'll have hypovolemia, they'll have dehydration. And those children, they need volume, they don't need inotropes, right? That other reasons in sepsis, as you know, in septic shock, sometimes the blood vessels leak protein. And so they have a capillary leak syndrome and they have low levels of albumin in the blood. And that leads to relative hypovolemia. So in the child, the element of septic shock that's hypovolemia just needs fluid. And then some children that have got severe sepsis, they'll have poor contractility. Their heart won't be pumping blood very well. So they'll have what we call a septic cardiomyopathy. Their heart's not functioning well. And they benefit from inotropes. I'll try to explain how to make this distinction clinically in a minute. And then usually in septic shock, children have vasodilatation, and especially if they've got a high fever, then they'll be febrile and they'll be flushed, and that they'll have a high cardiac output, but they have an element of vasoplegia, and they may benefit from an inotrope, especially noradrenaline. And then if a child with septic shock's got anemia, then they'll benefit from blood. So the way you manage the shock-like state in sepsis depends on the type of shock that's present and the type, I would say, the types of shock that present, because often it's more than one. It's often some of each: hypovolemia, poor contractility, a bit of or severe vasodilatation, and sometimes the hemoglobin's low and anemia. And you need to address all of these things in the resuscitation of septic shock. So not just giving adrenaline or not just giving fluid, but thinking about the balance from all these things. And so the mix depends on the type of sepsis the child has, the stage or severity of their sepsis, and whatever previous treatment they had. If they've been able to maintain their fluid status, if they, for example, have not been dehydrated, then maybe they've got more septic cardiomyopathy or vasodilatation rather than hypovolemia. So the history is important and the clinical examination is important. So the question is then, how can you tell? How can you tell what type of shock is actually present in an individual child? Well, you can assess the peripheral circulation. Do they look pale? And assess their capillary refill, their pulse volume, and their pulse pressure. If you've got a child who's got cold hands and cold limbs, cold hands and feet, and cold limbs, and their pulse pressure is very low, and they've got a marked tachycardia, they've probably got an element of hypovolemia and may have an element of cardiogenic shock as well. You can assess their signs of dehydration, which are a bit different if they've got sunken eyes or they've got dry mouth or they've got poor skin turgor. Probably they've got some dehydration as well as having an element of cardiogenic shock. You can assess their myocardial function. Sometimes you can assess it by echocardiography. You can also do some other things, measure their blood lactate. And if you've got a central line, then you can measure their oxygen saturation in the central venous blood. And if your central venous oxygen saturation is low, that suggests that the cardiac output is low, and it suggests that the cardiac function is poor. This is a bit complex, but in children that have low cardiac output because their heart's not functioning well, then their venous saturation, not their arterial saturation we measure with a pulse oximeter, but their venous saturation will be low. And it's low because their cardiac output is down, and so therefore not that much blood is going to the tissues. Therefore, the tissues extract as much oxygen as they can from the capillaries, and what the blood that then gets into the venous circulation has a very low oxygen concentration. So the SVO2, not the SPO2 or the SaO2, is actually low. And you can measure that by doing, if you've got a blood gas machine, by checking the venous saturation just on a venous blood gas, right? The venous saturation on a venous blood gas, usually from a central line, but also from a peripheral line, can give you a good indication of whether the heart's functioning well or not. Now, normally our venous saturation should be 75. That's what it is in our normal arterial saturation is 95 and above, isn't it? 99, 98, 99, 100. But in the venous circulation, if we've got a good cardiac output, normal is 75, 75%. But if it's less than 60, it suggests that there's increased oxygen extraction by the tissues, most commonly because of poor cardiac function. So I know I've taken a bit of time to explain that, but it's a new concept that if you have got a blood gas machine in your hospital and you can measure the venous saturation and you can measure the lactate, you can get a pretty good idea of what the myocardial function is like. Also, you may have access to echocardiography, and you can assess that to see how the heart looks like it's functioning. But if you've got a child, let's say you don't have those things, if you've got a child who's got cold peripheries and very poor volume pulse, low blood pressure, and weak pulses, then assume that they've got a poor myocardial function. Also check their hemoglobin, sometimes their albumin, etc. as well. Now, I know I said that the it inotropes are not meant to improve the blood pressure. They're meant to improve the oxygen delivery. But still, you need to know what the blood pressure is in a patient, and you need to know what's normal for age. Because even though we can't measure the cardiac output, we're usually targeting a blood pressure. We're trying to improve the blood pressure in these patients. And it's important to know what the range of blood pressure is for different ages. I've just put here on this slide the range of systolic blood pressure and the range of diastolic blood pressure. And I've put something else that is very important, I think, and that is the pulse pressure. Now, the pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. And the pulse pressure is when you've got a very constricted circulation because there's not enough blood in the circulation, maybe because of severe dehydration or because of hemorrhage, then usually your pulse pressure will be very narrow. It might be 20 or 25. When you've got a widely dilated circulation because of vasoplegia from sepsis or anaphylaxis or whatever, then your pulse pressure will be quite wide, and it might be 50 or 60. It does differ for ages, and it's useful to know what the normal pulse pressure is, because when you feel the peripheral pulses, when you feel the radial pulse or the dorsalis pedis pulse or the posterior tibial pulse in the feet, what you're feeling is the pulse pressure. And that can tell you quite a lot about whether it's a very constricted circulation or a dilated circulation. So you can get quite a good idea of how well the heart's functioning by feeling the pulse and by knowing what the pulse pressure is. As you can see, the normal pulse pressure for a school age child is somewhere around about 40. And it's 40 for even an infant. It's only for a neonate that it's around about 35. An adult, 40 to 50. You think about, a good blood pressure for most people is like for most adults is like 120 on 70. And so therefore the pulse pressure is 50. That's a good blood pressure, right? If you if an adult has a uh, um, cardiogenic shock, then their blood pressure might be 90 on 70. And so their pulse pressure is only 20. They'll have a constricted circulation because their heart's not functioning well, and their blood vessels are trying to constrict to maintain their blood pressure. So the pulse pressure tells us a lot about the way the heart's functioning. Okay. So in a child who's got hypotension, and remember, I should say, in regard these blood pressures, you don't need to aim for um, what's completely normal. It's good if you can get it into the normal range, but if you can get it close to the normal range, that can sometimes be adequate. And so this is the lower limit of the systolic blood pressure, and that's perfectly fine. The lower limit is fine to achieve. So if an infant has a blood pressure of 80 on 55, that's fine. And that infant will have a pulse pressure therefore of 35, and that's okay, right? So the point being, you don't need that's sorry, it's 25, but the point being you don't need to achieve um, the upper limit of normal range for the blood pressure. You just need to achieve a blood pressure that's good enough to provide an adequate oxygen delivery to tissues. And usually that's by having an adequate systolic pressure and having an adequate pulse pressure. So if you've got a child who's got hypotension, their blood pressure's lower than the normal range, then you need to think about whether or not this child's got warm shock or they've got cold shock. And so if a child's got warm shock, then they'll have often vasoplegia. Their blood vessels aren't constricting, they've got a fever and they're vasodilated. And so they'll often have warm limbs and they'll have strong pulses, and they may have a large pulse pressure, like more than 50 millimeters of mercury. And they'll have, if you do an echo, they'll have strong contractility. That you look at their heart and it's pumping quite strongly. And that child will often look like the febrile, vasodilated patient. And those patients, they sometimes need a bit of fluid volume, and they may need a low dose vasopressor. Not so much an inotrope. They don't need something to drive their heart because their heart rate is usually okay. In fact, it's usually fast, and their contractility is often increased. Their stroke volume is increased. So they might just need, after some volume um, and treatment of the rest of their infection with antibiotics and other things, they might just need a low dose vasopressor. Of course, they need antibiotics, they need source control, and you need to assess whether there's anything else that you can fix, such as if their hemoglobin's low, they might need some blood, or if their albumin's low, you might need to fix that, or if their sodium is low, you might need to fix that. But in terms of inotropes, they might just need a little bit of noradrenaline, and I'll explain how to do that. And then they need source control. I see a lot of children that are like this that get all of these treatments, but nobody thinks about source control for the infection. But you need to try to find the source of the infection and make sure there's no pus that needs to be drained or some ischemic tissue that needs surgery, for example. Very important source control. Otherwise, you just end up giving inotropes or vasopressors and antibiotics, and you don't get control of the infection. But that's warm shock, right? And then some children, though, if they present in the sort of later stages of septic shock, they'll have cold shock, and they will have in cold shock, the heart is now not well functioning. In warm shock, the heart is usually increased in its contractility, but in cold shock, there's been a decrement in the contractility, and the cardiac output will be low. So decreased contractility, sometimes usually hypovolemia as well, and usually it's in the later stages. So they're the children that instead of looking warm and febrile and flushed and often a bit more red than normal, they'll have pallor and they'll have very cold peripheries, even to their knees or higher, and they may be hypovolemic if they've got a setup for dehydration or their albumin is low, and they may have very poor contractility, and you can assess this by their clinical features, and also if you can do it, their lactate will be high and their venous saturation, either measured through a central line or through their peripheral veins. If you can do a blood gas, their venous saturation will be low, often less than 50. And when you look on the echo, instead of good function, they'll have very weak myocardial function. Their squeeze will be very limited. All right. In those children, instead of noradrenaline, because they're already very vasoconstricted, don't give noradrenaline because that'll vasoconstrict them more. The best agent to use is adrenaline, and that increases contractility, and it also causes some vasoconstriction, but nowhere near as much as noradrenaline. So those patients need just adrenaline. Okay, I just want to show you a picture of a child or a video of a child, and I think you'll see what I'm talking about in terms of cold shock. So I'll just show this video.
She had school yesterday.
Yeah.
No, today's Monday.
Today's Tuesday. We saw yesterday.
Tuesday.
Yeah. Yes, you are.
So you can see this boy he's had 24 hours of fever and vomiting, lethargy and vomiting, and he presents quite rapidly. And you can see he looks a bit dry. He looks quite pale. He looks like he's got some dried, cracked lips, and he's very unresponsive, isn't he? He's unresponsive to voice, he's unresponsive to touch, he's unresponsive really with his eyes. I want you to just look at the way he's breathing. And you can see he's somewhat tachypneic as well with his breathing. Now just have a look at his feet. And you can see how pale his feet are, and you can't see on the video, but his feet were very cold. And the point is to recognize cold shock. And this is a child who had cold shock from meningococcal disease. He did very fine when he got the right treatment, but he presented with really cold shock. And I think it's a useful way to understand it. Cold peripheries, very prolonged capillary refill, low volume pulses, looking really lethargic and pale. So this child needed fluid volume. First of all, he was hypovolemic, 24 hours of fever, lethargy and vomiting. And so he's hypovolemic, so he needed 2 lots of 20 ml per kilo of fluid. And then, because even clinically you can assume that he's got myocardial impairment. He's not a warm shock child. He's not febrile and dilated. He's got cold peripheries. Start some adrenaline. So he needed 0.1 to 0.2 micrograms per kilogram per minute of adrenaline. And as I said, he did fine with that treatment, fluid volume plus some adrenaline. I'll explain about adrenaline now. I mean, the question of when to give adrenaline. Well, firstly, when you see a child, you see that immediately you see that they've got myocardial impairment, either because you've got an echo or they've got severe hypotension or they've had an arrest. Then of course they need adrenaline. And if you see a child who's got cold shock, they need adrenaline. They need volume as well, but they will need adrenaline. For some other children, they won't be in that very severe state, but when you start giving them some volume, like 20 to 40 mils per kilo of fluid over the first hour or so, but still their shock doesn't improve, their blood pressure remains low, or their lactate is high, or their features of shock remain, then you should start them on some adrenaline. And in that way, the adrenaline is augmenting the fluid you're giving and the antibiotics you're giving and the way you are trying to achieve source control. Now, sometimes once you've got to 40 mils per kilo of fluid, if you don't give inotropes like adrenaline or noradrenaline, then you end up needing to give much more fluid, and then the children get very fluid overloaded, their lungs get wet, they get edematous, and that's not a good thing. So always after 40 mils per kilo of fluid, if I've given 10 and 10 again and 10 again, and they're still in shock or they're still cold, then start some adrenaline or some noradrenaline. And if they're in warm shock, give noradrenaline. If you think they're vasodilated, if they're in cold shock, give adrenaline. It's as simple as that. And if you've only got adrenaline, that's perfectly fine. Just use some adrenaline. I also use adrenaline in children with septic shock prior to intubation, if you need to intubate them. I won't go through this too much, but if you've got a child who's got septic shock and you need to intubate them, then you're giving a lot of agents that lead to a reduction in cardiac function. Those induction drugs that the anaesthetist will give lead to reduced myocardial function. They negatively inotropic, that is, they reduce cardiac contractility. Also, when you're anesthetizing a patient, you're blunting their adrenergic and their sympathetic responses. So that instead of having the normal or higher levels of catecholamines, you blunt that completely. So therefore, their blood pressure will drop. It almost always happens. And then when you put them on a ventilator, they've got positive pressure, and that can reduce their venous return. And so for all those reasons, prior to intubation, if you can, like if a patient's not arrested, then if you can, start them on some adrenaline. I won't talk about that too much. I'm really trying to focus in a way more on number 1 and number 2, the indications for using adrenaline. And I want to now explain how to use adrenaline. Now, not if in most places you won't be able to put in a central line. You might learn how to do that, a femoral venous line, or even a internal jugular line or a subclavian line. You might learn how to do that. But if you can't and you don't, then you can run adrenaline through a peripheral line as long as the concentration is not too high. And this is the best way to do it. You put 6 milligrams of adrenaline, that's 6 vials of adrenaline in 1 liter of fluid. And usually we could use normal saline, usually you'd use normal saline. And you run it at 1 mil per kilogram for the child's body weight per hour. So if a child weighs 12 kilos, you run it at 12 mils an hour. And what that is 0.1 micrograms per kilogram per minute. I won't go through the calculation, but mostly the dose that we want to run of adrenaline is about 0.05 to maybe up to 0.2 micrograms per kilogram per minute. And I always start typically with 0.1 microgram per kilogram per minute. So that's the way you do it. There are other ways to do it, but I won't explain those. I think this is the best way. If you can run peripheral adrenaline like that. If you've got a central line, that's different. I'll explain that. But mostly we're running, to start with, you're running adrenaline through a peripheral line. The most important thing is that you check every 15 minutes or 30 minutes for erythema around the IV cannula. You make sure you've got a good cannula. Check for swelling or blanching or any pain that the child might have, because adrenaline, if it extravasates, can cause tissue necrosis. So it's really important you've got a good IV line. Usually this is very safe for 6 to 12 to 24 hours, as long as you have people who can check the IV line regularly. And if the patient's got pain from it, then you stop it. As I said, there's another way to make up adrenaline, but I think this is the best way. 6 milligrams of adrenaline in 1 liter and run at 1 mil per kilo per hour and that gives you 0.1 mics per kilo per minute. That's sort of what you want to do. And if you ran it at 0.5 mils per kilo per hour, then you're down to the lower dose of 0.05 micrograms per kilogram per minute. Or if you go up to 2 mils per kilo per hour, so the 12 kilo child you're running at 24 mils, then that will be 0.2, which is, let's say that's the sort of maximum you want to run it to start with. I won't go through the prescription for central line adrenaline, but I've just listed it here, and that requires you to have syringe pumps, so 50 ml syringe pumps. But now, just any time you're running adrenaline, you need to be aware that there can be some side effects. And one, the blood pressure might come up, but you might lead to hypertension because of excessive vasoconstriction or driving the circulation faster. It almost certainly will lead to tachycardia, and it might actually even increase the blood lactate. And that's a metabolic reason. It's not because the cardiac output is reduced. It's a metabolic reason. That is, that adrenaline stimulates glycolysis, the breakdown of glucose in the skeletal muscle that gets converted to pyruvate, and that can sometimes exceed the mitochondrial capacity to process that pyruvate, and then it gets converted to lactate. So it's more it's a metabolic pathway that can be stimulated by adrenaline. But the main thing is sometimes it leads to tachycardia and hypertension. I want to touch on the use of steroids. I won't say too much about this, but the use of steroids as an inotrope, and certainly for children with septic shock, using some steroids can augment inotropy. That is, whenever I'm using adrenaline or noradrenaline for children with septic shock, certainly those children need or benefit from hydrocortisone or prednisolone or dexamethasone, whatever you've got. Just choose one, whatever you've got. Hydrocortisone, there's best evidence for hydrocortisone, and usually you give 1 milligram per kilogram every 6 hours. There's some evidence for using an fludrocortisone too, but I won't talk about that. If we've got access to hydrocortisone, using 1 milligram per kilogram every 6 hours is good. It's beneficial for children with septic shock, and it's beneficial for neonates with hypotension, with refractory hypotension. Best to only use these drugs, whether it's adrenaline or noradrenaline or hydrocortisone, use them for relatively short periods of time, 2 to 3 days. Mostly, if you've got source control, if you've treated the infection, then they're no longer needed. This is important. Yeah. Sometimes in some patients, if a child's on adrenaline or on noradrenaline, you've given steroids, you've given enough volume, you made sure the hemoglobin's okay, the albumin's all right, then sometimes using calcium can be a good inopressor. What that means is that it can stimulate the heart, and it can also lead to some vasoconstriction. And that's because calcium is required for that. For cardiac contractility, you need calcium, and for vasoconstriction, you need calcium. And sometimes we can use it as a continuous infusion, but only do that if you've got a central line. But if you've got a well-functioning peripheral line, then giving doses of calcium are okay if you've got a well-functioning, well-flowing peripheral line. I won't go through this in too much detail, except to say that if you have a child who's had an arrest, then giving adrenaline early is much better than giving it late. This is a very, very large study done of children who'd had an out-of-hospital cardiac arrest. It applies to children in hospital too, but if they got adrenaline early, then they were much more likely to have a good outcome. And that was an arrest from any cause of asphyxia or a cardiac cause or trauma or drowning or sepsis, that any cause included in these nearly 600 children who had an out-of-hospital cardiac arrest, and their survival was much better if they got adrenaline early. So that's all. I've got a case here I wanted to illustrate one aspect of adrenaline, and that is a child. This is a 6-year-old girl who had septic shock. And you can see for a 6-year-old girl, her blood pressure 85/52 is low and her heart rate is very high. She had, as you can see, she had very poor perfusion. She looks pale and she looks mottled. And she came on adrenaline of 0.5 micrograms per kilogram per minute. She was transferred from another hospital on adrenaline of 0.5 micrograms per kilogram per minute and noradrenaline of 0.4 micrograms per kilogram per minute. And if you remember what I said before, the sort of upper limit that we'd normally give is like 0.2 of each, adrenaline or noradrenaline, or sometimes both. Sometimes you can go higher, but sometimes when you do go higher, that can lead to some problems. And it can also lead you to think that the patient's, this is her perfusion. It's quite slow, and she's got quite she looks quite pale and cold and shut down. Her blood lactate was 6, so again, a high lactate. Her urine output was still okay. Her venous saturation was 62. Remember, I said if it's less than 60, you're in trouble. The cardiac function is probably not so good. And her central venous pressure was 3. Now, that's quite low, and it suggests that she's somewhat hypovolemic. Her sodium was 129, so that's a bit low. Her albumin was 16, and her hemoglobin was okay at 11. So instead of giving more and more adrenaline or more and more noradrenaline, the best thing to do in this circumstance is to give what she's lost. So correct her albumin level being low, give some blood if she needed it, or give some crystalloid, but be careful about not giving excessive fluid and reduce her vasoconstrictors and reduce the inotropes, because sometimes that will make things worse. So they were able to be reduced down to 0.2 micrograms per kilogram per minute after giving some volume. And then sometimes you just need to be patient and closely monitor the patient in the ICU. Now, this is another child, different. Oh, sorry, I'll just get that. Hey, Warwick. Can I call you back in about 10 minutes? I'm just giving a lecture. Okay, that's all right. Bye. Yeah, this is a 7-year-old child who had group A streptococcal infection. And again, he came on a similar regime of adrenaline of 0.4, noradrenaline of 0.4, was transferred from another hospital. And you can see his right leg is very cold and pale. And he's got ischemia, which is partly because of the sepsis and also partly because of the intense vasoconstriction that much adrenaline and noradrenaline gives you. So the treatment, again, for him, of course, the airway, breathing, circulation, give antibiotics, source control, but reduce the vasoconstrictors because they're causing some problems. And so he required some blood and some albumin, and you need to support his urine output, make sure his blood pressure is adequate for his urine output, and get him on some diuretics so that his kidneys don't fail, and then monitor him closely. So sometimes when you see a child with shock, you want to increase the inotropes and the vasoconstriction, and sometimes you want to reduce it because they're causing more harm than good, and you have to balance it all the time. I just wanted to touch on inotropes in neonates and say that certainly for preterm neonates with hypotension, 2 things are beneficial. One, certainly a bit of noradrenaline can help. We used to give lots of dopamine. We used to give dopamine to patients with for neonates, and now that's not often given. And it's not often given because that increases the oxygen utilization by the heart, and so it can make it can cause the heart to be in oxygen debt and not be as to pump as strongly because it's increasing the amount of oxygen that the heart needs. Noradrenaline seems to be better, and I won't go through all of this, but in preterm neonates who received noradrenaline, they had a better outcome than those who received dopamine. But also in preterm neonates with hypotension, steroids can be a benefit. So only a couple of days of steroids, hydrocortisone in preterm neonates with hypotension can be quite useful. And typically you give 1 mg per kilogram every 6 to 8 hours. And I try to give them only for 2 to 3 days, no more than that, because that increases, the shorter the better, in fact, because then you avoid the major risk, which is intestinal perforation. You should never, if you're giving steroids or other inotropes to preterm neonates, you should never give non-steroidal anti-inflammatory drugs too. You never give them ibuprofen or non-steroidal anti-inflammatory drugs, because that increases the risk of intestinal perforation. I won't go through the rest of it, but so look, that's all I really wanted to say today, but really just emphasize a few things. One, in a critically ill patient, then always ask for help. If you've got a child with shock, always ask for help. And these days we've got help from the anaesthetist, we've got help from, the adult ICU. Always ask for help from pediatricians who know about these things. Focus on the airway, the breathing, and the circulation. Manage the patient in an ICU area like this baby with a proper ICU monitor, and use a pediatric monitoring and response chart. So that's all I want to say about inotropes and vasopressors. I hope that's been useful. I'm going to stop sharing my screen and happy to answer any questions that you might have.